Hello, everyone, and welcome to part 2 of our magical insomnia tour. I'm Dr. Renee Kohansky, and this is episode 11 of Clinical Correlation. When last we met our hero, we were discussing our favorite off-label heterocyclic compounds used for insomnia, trazodone being the most popular by far. But also, let me give doxepin, a good old tricyclic antidepressant, an honorable mention. Now, with its extremely high anticholinergic properties and huge potential for orthostasis, guess to whom we're going to give it with caution. Yep, you got it, the elderly. But it's another tool for us to use, and it's a true antidepressant in its own right. However, if I were going to use a tricyclic for an antidepressant, doxepin is probably not my first choice. Why? Well, because of what I just said. It's hugely anticholinergic and orthostatic producing. So the caveat is caution with use in elderly patient. Now, here's where I find it has a place in insomnia land. Number 1, a patient on vilazodone, say with intractable diarrhea and insomnia. Or by the way, just incidentally, as an aside, nothing to do with insomnia, doxepin would be useful for a patient who we'd put on vilazodone, say for sexual side effects, and was doing great but had diarrhea. The anticholinergic properties of the doxepin could mitigate the diarrhea in vilazodone. So doxepin is a great drug, well, I would say a useful drug to use for sleeping in a patient who's on vilazodone. Number 2, place for doxepin, for a patient with insomnia and anxiety depression who's only partially responded to their antidepressant. Now, obviously, remember, you're dealing with the tricyclic, so all the necessary due diligence must be done, including looking at the QTC if it's indicated, and also monitoring BMIs, because obviously TCAs can cause weight gain. So we're talking about sleep, well, sort of, kinda, maybe wakefulness, which really is kind of a different thing, isn't it? So let's bring out what was once considered the big boys of sleep, the hypnotics, also known as the anxiolytics, the once favored, now dreaded benzodiazepines, affectionately known by some as the PAM sisters. They are called benzodiazepines because their chemical structure is a benzene ring, yup, you guessed it, fused to a diazepine ring. Oh, gosh, I may very well come back and devote a whole program to these molecules. When I think of benzos, I think of Virginia Woolf, Valley of the Dolls, the late great Elizabeth Taylor, as I'm just at the edge of the baby boomers. So, mechanism of action. Benzodiazepines bind to the GABA receptor, different GABA site than the Z drugs, which increases the frequency of chloride channel openings, thus resulting in increased neuronal concentration of chloride. This causes hyperpolarization of the neuronal membrane, making it difficult for excitatory neurotransmitters to depolarize the cell. Hence, a quieter, more chill cell. Hyperchloride, think hyper-chill. So, a couple of pearls on benzos. 1, these are like just little cute things to know. 3 benzos are metabolized via glucuronidation versus oxidation, and they are, in no particular order, lorazepam, temazepam, and oxazepam. Why is this important, you may ask? Well, I'm going to tell you. Because glucuronidation is a heck of a lot easier than oxidation for the liver to handle, and there are no active metabolites. I kind of think of this like glucuronidation is the liver just putting a clunk of molecule at the end of the active compound, and you just poop out the now inactive compound, easy peasy, no mess. Well, kind of, sort of. Okay, so now 2. In theory, anyway, an individual can become tolerant to the hypnotic effects of benzodiazepines and not the anxiolytic effects. This is more useful for an anxiety lecture. But sometimes patients take an HS dose initially as a hypnotic, and it serves to kind of reduce their sleep anxiety. So while it's not the ideal situation, some may stay on the medication long term where it's acting more as an anxiolytic to get them to sleep than as a hypnotic. Now, I'm not saying I like this strategy. I'm just saying why it may work. 3, and this is actually probably the most important, in my opinion, benzos are not the ideal agent for sleep, and almost never are they my first line for sleep. Truly, they really are not. And of course, that being said, sometimes for short periods it may be necessary. And of course, that being said, there are always exceptions to the rule, meaning that even though you're using it for short periods, they end up being long-term drugs. But I avoid it as much as I can, and sometimes we all inherit what we inherit. Now, I do believe there is a role for benzos in the treatment of anxiety disorders, but it's difficult and a program in and of itself. The problem with benzodiazepines is often when you start a benzodiazepine, you could be marrying a patient to the benzo for life, and you have to ask yourself, is this really a marriage made in heaven? And this is actually part of the informed consent. And of course, that being said, I'm going to come back to the point that there's a place for benzodiazepines, particularly in refractory anxiety disorders. And everybody out there who's been practicing for any length of time and has had those really anxious patients knows what I'm talking about. But it's a very, very delicate walk, and you have to do it with a lot of informed consent. Okay, now for the elephant in the room, which is kind of funny because for whatever reason, elephants are supposed to have good memories. And this elephant has a terrible memory. In fact, it's the Alzheimer's elephant. And I'm going to refer you to an article in the MD Edge Neurology in March of 2016, which discusses the fact, and this is interesting, that benzos may not have the increased risk of Alzheimer's we all believed. And then I'm going to blow your minds because I'm going to refer you to a recent Psychiatric Times article just this past January in 2021, which has a review of the literature looking across many studies. Bottom line on this article, it says, caution when using benzos in older adults because it may be associated with Alzheimer's. Alrighty then. Back to square one. Maybe. Well, I refer you to both articles, draw your own conclusions, and I advise what I always advise. Can you guess? Informed consent, informed consent, informed consent. This is the essence of the doctor-patient relationship. So next, I'm going to throw out another tried and true. Isn't it interesting how so many of these agents do double duty in anxiety? Gabapentin. Here are the pearls. Number 1, it's renally excreted, so it doesn't necessarily interact with a lot of our other drugs, which all of them go through the liver. Well, everything goes through the liver, except if it goes through the kidney, like gabapentin. Number 2, because it's an anticonvulsant, like the anxiolytics, it's going to calm things down. Now, number 3, you all probably know this, but in case you don't, but you probably do, there are dosage forms other than the 300 milligram capsule available, like, say, for instance, 100 milligrams. So you can dose lower during the day if you're treating anxiety. Number 4, going the other way, you can theoretically dose higher than 300 milligrams in one dose because it's dosed higher than that to treat seizure disorders. Number 4, this is kind of cool. Many people can't sleep because of restless leg syndrome, and gabapentin 600 milligrams XL is used to treat RLS. However, this is the rub. This is the rub on everything we do. This is medicine in this era. Often we can't get the XL formulation, even when you go for the prior authorization, even if you've got a documented RLS. So, by the way, here's my workaround. I have found anecdotally, because after all this is clinical correlation, gabapentin 600 milligrams non-XL has relieved RLS, at least in 2 cases that I have. Again, like I said, this is clinical correlation. Maybe it worked because it was sedative and it reduced anxiety. And maybe my patients slept through the RLS and they still had it. Don't know, don't care, it worked. Okay, so I'm running out of time here, but I really do want to mention a few other things. On the wakefulness side of things, or what I really mean is decreasing wakefulness, we have drugs that decrease wakefulness. These are the orexin receptor antagonists, and they are suvorexant and the newest kid on the block, lemborexant. And I'm going to refer you to an article in MD Edge in November of 2020 on the latter. So these guys come with essentially the same effect profile as the Z drugs, with the retrograde, anterograde amnesia, and complex sleep behaviors typically occurring during the non-REM sleep cycle. Okay, now let's not forget our basic, the simple guys, because we're getting all these complex, the orexin receptor antagonists and the Z drugs, but we also have hydroxyzine and even over-the-counter diphenhydramine. But let's not forget, anticholinergic, antihistaminic properties are not without risk, particularly in the elderly. I can't emphasize that enough. And all of my consultation liaison psychiatrists and my geriatric psychiatrists are going to say, yep, Dr. K, you got that one right. All right. And let me also make a mention that there's a place for the major tranquilizers, the second-generation antipsychotics, the atypical antipsychotics, for insomnia, of course, off-label, sometimes as a once or twice kind of things. More, again, this is a clinical correlation, and I've used this kind of as a circadian reset. You can also, again, this is informed consent, right? Because we have the tardive dyskinesia risk-benefit thing. But there's also, I've seen people using quetiapine 25 milligrams long-term for some people. Again, there's a correlation with severe anxiety disorders and maybe like you have an axis 2 component. And there's, there's kind of a stickiness to the person where you're using it like a psychic glue, putting them to sleep, but there's something else there that you're treating. And it's a clinical experience. Again, I'm telling you, this is informed consent land because you're looking at a tardive dyskinesia risk, and then you're going to also have to be doing your Ames test, even if you're only doing a 25 milligram quetiapine. And I think if you're using 25 milligrams quetiapine at night for sleep, you're treating more than just a sleep disorder there. Okay, so I haven't devoted any time to non-pharmacologic methods, and I actually have a lot to say about that because before I go to the pharmacology, I'm usually in non-pharmacology land, and I'm actually probably doing a combination. And I need more time, and I'm not going to cover that here. But I'm going to say that I am a huge believer in guided imagery, calming the mind, counting, breathing. And let me know in the comments section if you want to hear more about the techniques and strategy that I deploy. And also, you know what? I really want to hear what you guys are doing because we are all benefiting from each other. And I will respond to your comments. So really, let's hear what we got to say to each other. So concluding, this is a complex topic. There's lots to say about it. There are lots of different pathways operating, and there are no easy answers, no easy fixes. When people have cancer, they take chemotherapeutic agents that cause hyperemesis and disfigurement. They irradiate their bodies and prophylactically remove lymph nodes and organs. These are willing choices and decisions they make. We cannot remove the risk that life is. We honor our patients by respecting their autonomy and their decision-making process. In this increasingly litigious world with a frighteningly increasing cancer culture, it becomes more and more challenging to practice the art of medicine. But we can. We serve our patients with honesty about the limitations of our treatments, but by still offering every single thing we have, limitations and all. Then, most importantly, providing the information and guidance for them to make their own informed decisions regarding what is best for them. I'm Dr. Renee Kohansky for Clinical Correlation.